behalf of Indian Society of Organ Transplantation, I welcome you this uh, EduConnect webinar on a machine perfusion in disease organ transplantations. I welcome you all on the behalf of Indian Society of Organ Transplantations. As you all know, the importance of uh, uh, outcomes, basically the perfusions is important in then improving the outcomes and thereby increasing the utilizations. So today we have an very expert panel from the Kaveri Hospital, Chennai. So we'll be discussing on the multiple aspect of organ perfusion. Basically, we are fortunate to have three eminent expert from the same hospitals, and they will be sharing their experience. So I welcome you all. Dr. Saurabh and Dr. Pratik Das will join soon. They are stuck up in transplant surgery. So hopefully, if they free, they will join. So we'll starting with this. So I welcome you all. So first, for today's, we have a 3 minute speaker. So our first speaker is Dr. Balaji Krishnan. Sir is an senior nephrologist and transplant physician and has special interest in the disease organ donor transplantations and improving outcomes. Uh, Sir will be speaking on machine perfusion, its principal outcome, and he will share their experience of a Kaveri Hospital. Our second speaker will be Madam uh, Dr. Anu Ramesh, ma'am, and ma'am is a consultant urologist and renal transplant surgeon at a Kaveri Hospitals. And ma'am has a significant expertise in renal transplantation and advanced surgical technique like robotic transplantations. I welcome you, ma'am. Ma'am will be speaking on how to use a machine perfusion, and it's a practical aspect, basically an implementation part. And we have our third eminent speaker is Dr. Swaminathan. Sir is an director of liver and multi-organ transplantation and advanced hepatobiliary surgery, Kaveri Hospital. Sir basically will be speaking on liver transplantations and machine perfusion and how to improve the liver transplant outcome in a machine perfusion, basically beyond the transplantation beyond the kidneys. So I welcome you all three in this EduConnect ISOT webinar. So we'll be having a first talk of Dr. Balaji Krishnan, and sir will be talking on a machine perfusion principal outcome, and then he will be sharing his experience. So we'll be starting our first talk. So I request Dr. Balaji Krishnan. So please, sir, the stage is yours. Please.
So Dr. Balaji will be presenting from my account. He's just having some difficulties with his system.
Okay.
Right?
Yes, 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 yes. No problem.
Sorry about that.
No problem, no problem, sir. Thank you, sir. We are fortunate to hear you. Please.
Share presentation. Share.
Himanshu ji, can you help?
Can you just share the presentation?
I have given the rights, basically. Yes. It's visible?
Yes, yes. It is visible to us.
Yeah.
Fair enough.
Yeah. Good evening, one and all. Thanks, ISOT, for giving us this opportunity, Dr. Manish, Dr. Sarab, and Dr. Amol. In the next half an hour or so, we would like to share our experience about machine perfusion in organ transplants. And first going in the background about a little basic science behind it. Why should we perfuse? What are the solutions? What are the ways of perfusion, the types of machine perfusion, and at last I would be telling about our experience. So why perfusion of an organ? There are two main sources of kidney graft injury. One is at the time of organ procurement, And of course, at the time of reperfusion, which is called the ischemia reperfusion injury or the IRI, which all of us are familiar. So aims of all the modern kidney storage solution include control of the cell swelling during hypothermic ischemia, maintenance of the intra and extracellular electrolyte gradient, buffering the acidosis, provision of energy reserve, and minimization of the oxidative reperfusion injury. So we all know that after organ retrieval in an ischemic condition, there is no oxygen. It leads on to anaerobic respiration. There's buildup of lactic acid. Intracellular enzymes get activated. There's lysosomal damage. There's impaired sodium potassium ATPase, which results in a passive inflow of sodium. There's a buildup of intracellular calcium, which in turn leads to cell swelling and damage. So after the reperfusion, what basically happens is that the sudden increased demand of oxygen. So there's a lot of interaction with the anaerobic metabolites, which are already there with the oxygen, leading on to the formation of reactive oxygen species. There is lipid peroxidation of membrane, cellular damage, increased cytokines, activation of damage-associated molecular proteins, and which in turn leads on to endothelial injury. So now, why is ischemia reperfusion injury so important, and why is it so significant, and why did this organ perfusion come up? So we can divide this into the cellular and the tissue and the benign. It does not lead to, it's not like that. So as we see in the figure, there is a lot of functional overload which happens, which leads on to tissue hypertrophy, which in turn leads on to suboptimal graft function. And at the clinical level, this is one of the important causes for long-term chronic allograft damage. There is no single storage solution. It seemed to combine all the factors which are necessary. The original solution was the Collins and the Eurocollins solution, which is no longer available. The currently available solutions are the University of Wisconsin and the HTK solution, which is most commonly used. Now, this slide is about the European Association of Urology guidelines on the perfusion solution in 2025. They say the strength of recommendation is strong with the UW or the HTK solution for cold storage. Whenever there is nowadays we use HTK for most of our transplant. I've just listed out the basic differences between the UW, which
Himanshuji, please try to connect.
He's logged out. I'll just call him up.
Yes, please. You have a number. Please call him. I think there is a technical glitch. We have to wait for some time. He's trying to connect.
we have to share again.
He's back.
Yeah. Am I audible now?
Yes, ma'am. Please.
Sorry, extremely sorry. So the types of organ storage, there are two
Slides
different
are not
types of
shareable,
organ
sir.
storage, which is, we all know that the first one is the static cold storage, SCS. Pardon?
Muted?
Pardon me, is it muted?
No, sir, you're audible, sir.
You are audible, sir.
Organ storage, what we all know, one is the static cold storage or the SCS, and the other one is the dynamic perfusion. The static cold storage, as we all know, is just basically the organ which is taken and then perfused with RL, with heparin, and then we just put them in the ice water, and then we take it forward. We have been following this for many years, and that is the static cold storage. The advantage is it's cheaper, it's easier, does not require any expertise or manpower. But at the same time, there's no standardization available. There's no standardization which is available. We are not able to compare the outcomes based on the static cold storage. We cannot assess the organ viability and cannot ascertain the ischemic damage which is there. So why machine perfusion? Extended criteria donors experience a worse post-transplant outcomes, and they are more vulnerable to ischemia reperfusion injury with compared with standard static cold storage alone. So moving towards the most sophisticated improving organ viability and expansion and liver also. So the dynamic most commonly used is the hypothermic machine perfusion, otherwise called HMP. We add oxygen to this, which is called the hypothermic oxygenated machine perfusion, this otherwise called HOPE, normothermic machine perfusion, and then we have the subnormothermic machine perfusion and the subnormothermic regional perfusion. So now moving on to this diagram, which says that various organ assist company, the organ recovery systems, the IGL group, they in turn have a perfusion solution with their name, and all of them have developed into an easily portable kind of a machine which can be easily transported, as compared to the original one, which was shown in the top left figure. So the currently available tools for preservation are, which are available in India for the resuscitation of marginal donor, and the HOPE, which is Vita Smart. So hypothermic machine perfusion, what does it do? So basically there is a kidney machine perfusion. It supports the kidney's basic metabolic requirements. Nutrients and oxygen are provided with the perfusate to support the basal energy metabolism and the ATP production. There's elimination of toxic metabolites and free radicals. So the toxic byproducts are flushed out and diluted with the perfusate. Preservation of the endothelial cell function, and there's increased vasodilators and anti-inflammatory genes, which have demonstrated increased nitric oxide, which has been seen demonstrated in animal models. There is a decrease in the endothelin level. So these all have demonstrated that it is more favorable for the endothelial lining of the kidney. In fact, there are studies to show that continuous and pulsatile machine perfusion, the EUA recommends the pulsatile machine perfusion to be more physiological, because they give physiological stimulus for the endothelium to release nitric oxide. So there are so many biological benefits of this hypothermic machine perfusion. So the EUA guidelines is the one strong authority which says that which supports the use of machine perfusion. The summary of evidence is nearly 1A for hypothermic machine perfusion of diseased donor kidneys, which shows a reduced risk of delayed graft function. And there's a strong recommendation to use HMP wherever it's available, even in standard criteria disease donors. And they also recommend they use low pressure values and to prevent pressure injury to the endothelium, which can in turn trigger a lot of other reactions. So there are a few guidelines given by this EUA, which can be the backbone for EAU, sorry. So the latest data is from the Mayo Clinic. This was a retrospective cohort analysis from the year 2014 to 24. They had included adult dialysis-dependent recipients of the deceased donor kidneys preserved using either static cold storage or HMP. The primary outcome was delayed graft function. In this study, the matched pair analysis, there was significantly lower delayed graft function rates with HMP as compared to the standard cold storage. So therefore, this is much beneficial. So moving on to our experience. So we wanted to assess the viability of kidneys based on the machine perfusion parameters. We assessed the delayed graft function rates across various KDPI categories. We had divided the donor kidneys into low KDPI, less than 35, intermediate 35 to 85, and high more than 85. We assessed the short-term graft loss. We also were able to compare the graft survival at 3 and 12 months with static cold storage, standard criteria kidneys using the serum creatinine. Now, this was the materials and methods. It was a comparative study done from March 2019 to 25, where 52 marginal kidneys were used and 34 kidneys were machine perfused, out of which 32 were transplanted. We had to discard 2 kidneys. One patient underwent dual kidney transplant where the second kidney was perfused. 20 kidneys were perfused in the HMP lifeboat, while the 14 were perfused in the HOPE machine. The flow in ml per minute and the renal resistance at 15 minutes, 1 hour, and at the end of perfusion were analyzed. Kidneys which did not meet the validated perfusion parameters were discarded, and we used the outcome as the DGF as per the previous studies, which we defined as the need for dialysis within 1 week, and also compared with the standard, with the static cold storage standard criteria donor kidney. We evaluated the graft survival at 3 and 12 months using serum creatinine and compared it with the kidneys. 32 out of the 34 kidneys were implanted and 2 kidneys were discarded based on the physical appearance of diffuse mottling and poor perfusion parameters. The average flow rate ranged from 86 to 95 ml at 15 minutes. It increased to 90 to 120, and at the end of the perfusion, it was even better. Renal resistance was starting, it was 0.25 to 0.3, and later at 0.2 to 0.8 at 1 hour. 28 donor kidneys belong to the intermediate and the high KDPI categories. 6 patients had delayed graft function, 3 each in the intermediate and the high KDPI. There was no primary non-function of the graft which was seen. The average creatinine at 3 months and 12 months were 1.4 and 1.2 milligrams respectively, and there was no graft loss. So the donor data, the average age of the donor was 47.6 years, and the terminal serum creatinine was 2.1. The cold ischemia time in hours was 10 hours and 38 minutes. And the KDPI, we had the comorbidities, diabetes, hypertension, and the CVA. So this is the kidney data. The KDPI, the low, there were none. The intermediate and the high KDPI, they had 3 plus 3 patients, 6 patients had delayed graft function. So this is the graph which I had already explained about the renal resistance and the flow. So thank you. Over to Dr. Anu Ramesh. She will be discussing about the practical aspects about the machine and the parameters more in detail.
Thank you, Dr. Balaji, for explaining the principle behind and your experience. Thank you, sir. And now we'll hear from Dr. Anu Ramesh, practical aspect of implementation of a hypothermic machine perfusion. Please, ma'am.
Just give me a minute. I'm also, I've been requested just to switch off the video because I think there's a shorter bandwidth. We'd like to get as much bandwidth as possible because we have a few videos which
Okay, ma'am. Okay.
be shown. Okay. So
Yes,
I'm just going to turn off, right?
Yes,
Thank
yes,
you.
ma'am. Please, ma'am.
How to go about using the machine as such and its practical aspects. So we'll just go through it bit by bit. First, coming into the components. So it consists of the machine, the ice chamber where you'll be filling it up with unsterile ice, the sterile container where it's going to be containing the perfusion fluid along with the kidney cradle. So here I'll be talking essentially about the hypothermic machines. One is a hypothermic machine alone, which is the Lifeboat 2.0, and the other one being the Vitus Smart, which is a hypothermic oxygenated. So here consisting basically will be filled with unsterile ice. Additionally, you will be having the lifeboat transporter system where within the perfusion circuit, you will be having the kidney in a kidney cradle and your perfusion along with here in your pump deck, you will have these various tubings. So these are the connections which we will be giving in, including the pressure sensor cable, in the bubble detectors which are going to be there. So don't worry if it looks a little like it's a bit too much because I'll be explaining it to you and showing it in a video form to actually how to go about the whole thing. And then this is the organ chamber or the kidney where we'll be placing the perfusion fluid. Along with that, the kidney in its specific cradle. So now, here, these are the various types of cannulas. Again, I will be showing it to you how exactly we go about it. So there are three types of cannulas. One would be just a cannula, which is going to be a straight cannula, it looks like a T. So these will be in case you don't have an adequate aortic cuff. These will be a seal type of cannula, where it will actually have a seal which is just sitting at the aortic cuff level. Most of these and then you'll have a complete seal one as well, which will be more like a cup. These cannulas are again going to be used based on whether you have an adequate aortic cuff or not, whether in case you can hope to lose a little, even if you lose a little bit of length, it may not make a big of difference. This, especially if you don't have an aortic cuff, it will be there more for a straight type of cannula. I will also be coming now to later on how we use it for multiple arteries as well. So this is where your kidney is placed inside the cradle. So now the pre-perfusion setup as such. So coming to filling up the ice chamber, you fill it up with unsterile ice. You will have to really stuff it well. Put in about 1 liter of nice cold saline and place it inside the machine. This is your sterile chamber. Here, you'll be filling it up with the perfusion fluid after removing the kidney cradle, setting it up again to make sure that we are ready to receive the kidney along with the cradle. This is the HTK solution which we use. We tend to use it better versus compared to a UW solution, as the viscosity is going to be lower for it to be perfused throughout. And now once this is placed, we place the inner lid followed by the outer lid. This inner lid has been placed. Now this is the other lid. This is then handed over and the connections are made. So what exactly are the connections which are going to be made? This is going to be placed inside the ice chamber. Connections to the pressure gauge and the tubings for the perfusion are made. Additionally, you have the bubble detectors here as well. And the pressure gauge and sensor, temperature sensors are connected. Now, initially, we first wash. We said we'll do a wash through the system, making sure that we remove as many air bubbles as possible. You will note that the first one is prime and third is infused. So initially, we wash it. We look at the various parameters which are present below. This we will start looking at more seriously once we have connected the kidney and we are perfusing the kidney. So then we will tilt it in various directions so that we are able to remove the air tract. Now, so we were looking into the cannula. So firstly, we need to see what are the retrieval requirements. So ideally, it's always nice to have a single artery. Your work is done. It's simple and with a good aortic cuff. But then we know that there are not always ideal situations. You could have operated by a distance, or you may have those without adequate aortic cuffs. So when you do not have an adequate aortic cuff, the straight cannula or the C-shaped cannula is the ones which are used. If you have an adequate aortic cuff, or you have vessels which are closer to each other, we can use these cup type of cuffs. So the various sizes which they come in our Indian population, that 5 millimeters seems to be adequate. Once we connect it, you can see that this is within the renal artery, just covering up the aortic cuff so that it will perfuse into the renal artery. So now coming into the basic cannulation, the priming and perfusion of the system. So initially, after we have made sure as many air bubbles have been removed, we start cannulation of the renal artery. So in this sort of cup type seal type of cannula, we will be pulling the renal artery along with the adequate aortic cuff into the cannula, sealing it well, making sure that there is no chances of leak. We should, otherwise what will happen is there is not going to be enough perfusion solution running through the system. It will be leaking throughout, and in fact, it may not do any help. In case of inadequate aortic cuff, you will be using a straight type of cannula or your T-shaped one. Here, or in case you have you do not have danger of internal, you're okay with losing a little bit of length. This is the only drawback of this system. You might lose a little bit of length, maybe the above 2 or 3 millimeters from the top, because you'll have to tie it down along with the cannula. We place the kidney within the cradle and fix it with the cannula. Once we place it in the cradle, we have to make sure that the kidney is not placed too tightly inside. Otherwise, it does not allow room for expansion. We put in a sterile drape over the system. After opening out the outer cover, the inner cover is maintained as you see. So now we have access, the surgeon will have access to the entire system now in a sterile manner. The inner cover lid is then removed. We place the kidney cradle inside and then make the connection through the cannula to the system. Now, in case there is an additional vessel which is slightly far apart, we place an intermediate connector which is there, so it will be perfusing through both vessels. Again, we'll be looking into removing any bubbles. After doing a prime for the kidney, then we will start to infuse. Now is when we will look into the various parameters, that is the pressure, the set pressure, what's the achieved pressure, the renal resistance. So this is when we've used a cup type or a seal type of cannula, which is there. Okay. Once the priming has been done, we're ready to perfuse the kidney. So again, we also use the HTK solution. And in this case, you can see these are in fact double renal arteries which are present, adequate aortic cuff, and they are closer to each other. Had they been a bit of a distance apart, then we'd have done a separate perfusion through a continuation system or a series with the second vessel. So what we have to keep looking out for, as we do in your regular regular perfusion, is whether there's adequate output coming out through the renal veins, and then looking into the pressures, flow, and renal resistance. So if you notice, I'm just going to pause this a little bit now. This is when we've just started the system, so it is only at 12 seconds. So the pressure which we have set it at 30 millimeters of mercury. What is the pressure which is achieved is what we're looking at. Then we're looking at the flow through the system and the renal resistance which is present. So any renal resistance below 0.3, set pressure which we're achieving at least more than 30, and then a good flow of anywhere above 80 to 90 is definitely showing a good functioning kidney. Additionally, if you see, there is a temperature gauge which is there. So for the pressure sensors going higher than 5 degrees centigrade, what will happen is it will start telling you to check the ice. So you have to make sure, you maintain the system cool. When you're keeping it inside the OT, say it's perfusing for some time, make sure that even the air conditioning is maintained well. See here, if you may, I'm going to pause this again. There is a good pressure which has been achieved, additionally good flow and a low resistance. So this is indicating a good perfusion through the kidney, and good perfusion parameters indicating it's a good kidney as well. In case of hypothermic oxygenated machine perfusion, this is an open system, not a closed, a little more of an open system in comparison to the hypothermic machine perfusion alone. So here you can see there is good outflow through the kidneys and good perfusion parameters where you can see there is a 0.21 achieved as the renal resistance. In this one, unfortunately, I think there's inadequate sealing, so you can see a bit of a leak around the kidneys. So here, in case again you're having multiple vessels, you do the same thing. You place it in series, so through one and then through the other. So now this was the other group, which is your hypothermic oxygenated machine perfusion. The additional advantage, the advantage with that would be the presence of an additive in your perfusion, that is oxygen. So this can additionally help. Now, in terms of timing, does it matter? Yes, it does. At least 4 hours of perfusion in case of a hypothermic machine perfusion. In case of an hypothermic oxygenated machine perfusion, 2 hours of perfusion at least is required, to make sure that the DGF rates are going to be lesser in comparison to static cold storage. So what are the data which we're looking into? The perfusion pressures, achieving pressure of at least 30 millimeters of mercury, a flow of more than 80 milliliter per minute, renal resistance or renal resistive index of at least less than 0.3. Now, when do you check it? You check it at the start of perfusion at 15 minutes and then 60 minutes, and always at the end of perfusion as well, because you're looking towards achieving these well-validated perfusion parameters to know, in fact, that your kidney is good to be used. So in case you can see both for your home machines and your HMP alone, both these organs have achieved good perfusion parameters. So in case these values are not achieved, what could it indicate? In case of an acute kidney injury, it could be due to microvascular thrombi, donor hypotension or peripheral vasoconstriction, donor hypertension or diabetes. For a couple of kidneys that we had discarded, as Dr. Balaji had mentioned, they did not achieve any form, in any of the categories, they did not achieve any form of perfusion parameters which showed that we could be using these kidneys. They had poor resistance, they had high resistance, poor perfusion, and in fact, these were used on the HMP machine. Dr. Balaji has already covered the advantages of machine perfusion over static cold storage, so I need not be going into that now. Our slight disadvantages are going to be in terms of access to the machines, to assess this, the expertise available, and the costs, of course. And with less, but if we're looking into balancing it out with lesser DGF rates and better graft survival, there is a balance in these cases, of course. So just to summarize, there is good evidence to show that there's a reduction in the delayed graft function rates and survival, is especially when it comes to ECD kidneys when they're preserved with HMP versus just static cold storage. There appears to be a minimum time benefit which is required for these patients, and increasing evidence which shows that there is a benefit in adding oxygen to the system. HMP is cost effective if you're looking into comparison of the patient being around for dialysis and additional costs as well. And there is an additional insight into the viability and quality of these kidneys. So boxing is not only about your feelings, it's about the performance. Thank you.
Thank you, ma'am, for you're sharing your practical experience. You have beautifully explained steps around the Hope and Life Port 2 machines. Thank you for your detailed explanation regarding the procedure. Ma'am, Dr. Swami, I think, is about to join. He's stuck up in the surgery.
No, he's come here as well. I think we're all using my system for the time being because all of us were as well. So
if sir is there, I request Dr. Swaminathan, he can start his lecture.
Just one moment.
Yes, 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 yes.
Just as the others were also in transplant, we also had a transplant in fact today. So
yes, yes, yes. Dr. Pratik is also busy in transplant.
so just
good only.
is it visible?
Yes, yes, ma'am. Yes, yes, sir.
Screen is visible. Okay.
So welcome, sir. I welcome you on behalf of ISOT.
Hi, hi. There might be a few slides overlap of content because it's I'm going to touch upon a few topics. So my slides will have why we are even talking about machine perfusion in the liver, what are all the types and options available for machine perfusion, what are the outcomes of machine perfusion in liver transplantation. So why we are talking about it, because we need to understand the preservation injury which happens at the start, which can be divided into pre-preservation injury, that is an injury that happens even before, and then the cold preservation injury, that's an injury that happens during the static cold storage. Rewarming injury is when we do the anastomosis, and reperfusion injury is when after anastomosis and reperfusion. So that's the several steps of injury an organ can incur while they're getting stored or preserved. So during the cold preservation injury, the whole idea of cold preservation, the static cold storage, is to reduce the metabolic activity to almost nil, but with various enzymes act at different temperatures, and even at that temperature of 0 to 4 degrees, there is still results in a gradual depletion of ATP. The different enzymes are susceptible to different temperature time points, and so this sodium potassium, for example, sodium potassium ATPase pump will be new to have almost 10% of normal activity. So at 4 degrees of metabolic activity is only 10% of the normal. When the sodium potassium ATP is inhibited, what happens is sodium gets influxed and potassium gets released out of the cell. And as the sodium moves in, more water gets pulled in. Intracellular, cell swelling happens, and intracellular edema happens. Cell wall lysis happens. Similarly, when during anaerobic metabolism, that's when there is no oxygen, ATP depletion happens quite rapidly, leading to accumulation of hypoxanthine and xanthine calcium, which then cell lysis. The kidney or the liver races quite rapidly, which leads to rapid depletion of ATP, and there is a time-dependent increase in the protease activity and cell damage. A few minutes of rewarming injury is equivalent to several hours of cold ischemia time, so it's crucial that we do the anastomosis quickly. So I emphasize to all my trainees that there is essentially a need for speed. For every 10 minutes, the temperature rises by about 4 degrees Celsius, which means by the end of by about 30 minutes, we are looking at almost 15 to 17 degrees Celsius, which is ATP depletes rapidly. So anastomosis is so the reason, because when we do the organ retrieval in cadavers, the warm phase, after the cross clamp, the cold phase of the retrieval, the organ gets warmed. So as soon as we take out, perfuse on the bench, pack the organ. And again, after benching, repack the organ. Don't rush back and take it to the recipient, try to implant, because during benching itself, the temperature can easily rise to 10 to 15 degrees. And then another 10, 15 degrees during anastomosis, you're looking at almost like a room temperature, which will lead to rapid cell death. Reperfusion injury, here the mitochondria is a domino stone of IRI. The lack of oxygen actually leads to ATP depletion, leading to succinate accumulation. And then when the oxygen is given, that leads to reactive oxygen species, and reactive nitrogen species are generated. They lead to endothelial cell injury, which activates platelet and leukocyte adhesion molecules, and they lead to a cascade of reaction leading to cytokine release. There is also injury mediated by damage-associated molecular patterns, and also injury caused by innate immunity and adaptive T-cell mediated immunity. So all the preservation fluids that we use in the static cold storage, they have components to mitigate the injury static cold storage. Each of them have a specific role. I'm not going to go into the depths of that. More susceptible for prolonged, susceptible to injury when they are stored for a longer duration of time, leading to delayed graft function in kidneys or initial poor function in liver, or sometimes even in worst case scenario, primary non-function. So as I mentioned, prolonged cold storage, but marginal organs are more susceptible, leads to delayed graft function, EAD, PNF, biliary complications like bile leak, anastomotic biliary strictures, and non-anastomotic biliary strictures. So the objectives of the machine perfusion is to minimize or prevent the cold preservation injury, to store for longer duration of periods, to wash out the accumulated toxins which happen during a period of static cold storage, like the reactive and oxygen species, to assess the viability of the organs while it's on the machine, and to repair or modulate marginal organs. What are the options available? We have hypothermic machine perfusion, hypothermic oxygenated machine perfusion, subnormothermic machine perfusion, which is not very popular, normothermic regional machine perfusion, normothermic ex vivo machine perfusion. What we have in India is hypothermic oxygenated machine perfusion. We had for a very short time NMP, normothermic machine perfusion, which is now out of market now. So I'm going to talk only about HMP and HOPE and livers. HMP is actually the hypothermic machine perfusion. Still debate goes on whether it has to be continuous or end ischemic. What I mean by continuous is you take out the liver and put it on the machine straight away. That is called as continuous machine perfusion. End ischemic is when you bring back the organ to your transplant center and then you connect. That is, after a variable period of static to cold storage, you then connect the organ to the machine. There are several studies to show that both continuous and end ischemic machine perfusion are equally good. And depending on the machine you use, you can decide which one you want it to. If it's a portable machine, for example, life port in kidney, you can take it to the retrieval center, take out the kidney, perfuse it then and there, and bring it back to your center. Or if you're using a HOPE, which is hypothermic oxygenated machine perfusion, which is not a portable machine, so you retrieve, pack the kidney or the liver, bring it back to your center, and a variable period of 4 to 6 hours of static cold storage followed by machine perfusion. The outcome is going to be the same. Pressure versus flow controlled, portal alone or hepatic artery alone, or a dual perfusion, pulsatile versus continuous, again, oxygenated, non-oxygenated. These debates been ongoing, but I'll talk about a bit more about all these things later. This is a life port liver transplanter, very similar to life port kidney transporter. It's not available in India at the moment. The one on the right side is a liver assist by Organ Assist Group, the Groningen Group. Again, that's not available in India. The life port liver transporter is a portable liver machine, just like the kidney one. This is not a portable one, so you got to do end ischemic perfusion. That is, you retrieve the liver, static cold storage, bring to your center, and then do a perfusion. This is an initial study of HMP livers in clinical transplant back in the James Guerrera group, the same group which developed the life port kidney as well as a life port machine. They included 20 patients, did a dual perfusion for 8 to 9 hours. After 8 to 9 hours of static cold storage, that is end ischemic perfusion. They showed less early allograft dysfunction, lower enzyme release, as well as shorter hospital stay and less biliary complications. Subsequently, I mean, it's their own paper. Further extended into ECD livers. This is a HOPE. HOPE is the hypothermic oxygenated machine perfusion. Here it's a single perfusion through the portal vein. You can see the cannula is connected to the portal vein, and that's one of our livers getting perfused. And that's a machine which displays all the machine parameters, the perfusion parameters. It's a portal flow in volume, that's a portal flow in pressure, and that's a resistance. So what does HOPE does in over and above the planned hypothermic machine perfusion is that when we give oxygen, what happens is it reestablishes the electron flow. It's a transfer of electron from complex 1 to complex 5. So that leads to ATP depletion and further accumulation. So when the oxygen is given, they form free radicals. So what we do in the machine perfusion in the HOPE is we give oxygen prior to reperfusion. So what happens is there is a slow release of reactive oxygen species which will get washed out by the perfusion, as well as the re-establishment of respiratory chain, and ATP gets recharged. And when we put the liver from the machine into the recipient, all these reactive oxygen species were already washed out, and so you don't have a significant reperfusion injury. So these are all some of the studies that looked into HMP and HOPE versus static cold storage in various settings, including DCD, ECD DBD, ECD DCD DBD. I mean ECD DCD versus ECD DBD, and ECD DCD combinations. Various studies, all of them have shown that. To just summarize, they all show significantly lower peak AST, ALT, and total bilirubin levels, decreased renal dysfunction rates, significantly lower rates of post-reperfusion syndrome and EAD, early allograft dysfunction, reduction in ICU and hospital stay, significantly lower biliary complication rates, and reduction in discard rates of marginal liver. Again, talking about the pre-ischemic versus end-ischemic perfusion. Pre-ischemic is at the time of retrieval, and then end-ischemic is after a period of cold ischemia. Studies have shown that there is no significant difference. However, the cold ischemia time can vary anywhere between 5 to 12 hours. Then the viability studies, and hope we have what is called as a flavin mononucleotide, which is released from the mitochondria during hypoxia. So FMN concentration in perfusion has shown to correlate with the liver function and graft survival in DCD livers. Now new portable HMP and HOPE liver transporters are getting developed, which should allow pre-ischemic perfusion of the livers at the donor hospital. So coming to normothermic machine perfusion, which is not available in India. However, we had the machine for a very short while in India when we used for a few livers. What's commercially available is a Organox machine. More than 30, almost a third of livers are now with at a body temperature using advantages. It prevents cold preservation injury altogether. Full metabolic support and sustains viability. We can assess the viability while the organ is on the circuit and resuscitate the marginal livers by pharmacological interventions. So this is again the organ assist liver assist machine, which can be used either as a HOPE or as a NMP. The initial animal experimental studies showed the feasibility and superiority of static cold storage, and the first human study was done by. This is the first study on discarded human livers done by the Groningen group, and they identified certain markers of viability and validated the criteria for functional assessment and viability. The first clinical trial was done by the Oxford group with 20 NMP livers compared with 40 mashed cold stored livers with a preservation time of about 9 hours. 30-day graft survival was similar, with median peak AST was significantly lower for NMP or machine perfused or normothermic machine perfused group when compared to the static cold stored. This is the Organox Metra, which is quite a portable machine. You can take it to the retrieval center, retrieve and perfuse. It's a dual perfusion. Both the portal and hepatic artery has to be cannulated. It is a liver assist by organ assist, which is not available in India. So again, there are a lot of multi-center randomized controlled trials in North America and Europe. To summarize outcome, it significantly lowers the peak and total bilirubin levels, decrease renal dysfunction, early allograft dysfunction, reduction in ICU and hospital stay. Biliary complication rates are not very well studied in the NMP studies, although we know that in HOPE itself, the biliary complication rates are significantly lower in DCD livers. And there is a reduction in discard rates of marginal liver. So I'm going to skip this part, which is our study. Machine still animal studies being done. We are still waiting to proceed to the next level. So normothermic machine perfusion is safe and effective. It's been less allograft injury and reduced hospital stay. Portable Organox Metra and other devices should allow NMP at the donor hospital and during transport. This is our data. the XYO machine perfusion of liver and kidneys. I think kidneys already our team has presented. Total livers perfused. So you can see a liver getting perfused here. This is a kidney getting perfused in a HOPE. This is kidney in a HMP. Perfused with Organox Met. Organox was available in India. We 24 hours, 22 hours before transplantation, and with the liver, the patient went home perfused with HOPE, and we in 31. One liver perfusion because of patchy perfusion, stiff liver with macrocytosis, more to discard one, and 5 we just brought the machine, but we really didn't use it. So indications, we try to use machine perfusion for all elderly livers, unstable donor, prolonged ICU stay, pre-donation cardiac arrest, deranged LFT. We anticipate some prolonged cold ischemia time or pre-operative imaging, pre-donation imaging suggests to a fatty liver. Then we call for the machine. We keep the machine as a standby, and then we do decide intraoperatively if the macrosteatosis is between 20 to 35. We use machine perfusion. If it's more than 40%, obviously machine is not a magic bullet. It's not going to fix a liver which is more than 40% steatosis. We won't use that liver at all. And again, in high risk recipients, when we think that the explant is going to take a long time, then we put the liver on the machine, and then we leave it on if the explant is going to take several hours. This is our data. 42 to 7 we've used in multiple elderly donors machine perfusion. 11 donors had even had elevated transaminases. One of the donor even had an enzyme of almost 2965 and AST of 2900 and ALT of 1100. And 14 cases we did biopsy. 7 cases visually assessed to be about 20 to 25. 8 cases had about 30 to 35% macrosteatosis in biopsy. Another 6 cases had 25 to 30% macrosteatosis. Cold ischemia time, anywhere between 6 hours to 14 hours. We perfused as long as 15 hours. We had livers with an extended cold ischemia time close to 15 hours. Machine time varied between 2 to 6 hours depending on the logistics. Recipient demographics, 6 out of our 26 recipients had AKI with a range of 1.9 to 3.1. MELD average is about 21 to 38. Just to summarize, our peak AST/ALT is not too bad. Lactates, you can see that it's not too high, 2.2 to 4.6. INR is about 1.3 to 2.1. Early allograft dysfunction in 1 case with a peak AST of about 3000 with EAD definition being more than 1000. We had 1 PNF. We couldn't salvage the patient, lost the patient. No short-term biliary complications. I should say that the most important aspect what we saw was less reperfusion injury, shorter ICU stay, less inotropic requirements in the post-operative period, less short, the peak lactate was lower, and we managed to use a lot of marginal livers which we would have otherwise discarded. That's the most important factor. We managed to use a few more livers which are like long distance livers, longer cold ischemia time, and marginal livers. So this is the national data. Primary non-function rate out of the 91 cases is about 7, which is about 7.6%, which is accepted. Acceptable rate with a high donor risk index. Extended cold ischemia time and severe steatosis, more biopsy showing macrosteatosis more than 35%. Obviously, as I said, the machine is not going to fix macrosteatosis sort of livers. Thank you.
Thank you, sir, for your elaborative talk. got to learn a lot from you. Sir, should we start a panel discussion, sir? I hope all three of you are there. Hello, can you hear me, sir? Hello.
सर नेट हॉल्ट हो गया उनका. इफ यू कैन क्लोज दिस वीडियो देन उनका बैंडविड्थ अच्छा चलेगा. मुझे दिख रहा है लो बैंडविड्थ पर है वो.
Just in case back.
Can you hear me, sir?
Yes. Sorry. Yeah, I think we got disconnected a little bit. Yes.
Hope you all three were three are there, sir. Should
We're all there. Yeah.
yes. Okay. We can start a panel discussion, sir. Sir, first question is you, sir, Swaminathan, sir, for you.
Yes.
Sir, are you regularly, in your hospital, are you using LifePort 2 or Hope machine? Which machine actually you are using presently?
So for kidneys, we use LifePort 2. We have it with us. And for livers, we use the Vitasmart's Hope machine. So we use both. Because the cost of Hope is now a little bit higher, we don't use it for kidneys. We use only HMP. Previously used to use Hope for kidneys also.
So what exactly the cost, for example, cost point of view, what is the difference between LifePort and Hope? How is the difference?
For Hope, the oxygenated circuit,
Yes, sir.
it's approximately 2.5 lakhs per case.
Per
So
case.
that's per case. Yeah, it's
Okay.
they bring the circuit, they bring the machine, they bring the perfusion fluid, they set it all up, and then you connect the liver or kidney to it.
It's like a rental type model.
The rental type, yes, exactly. Yeah.
Okay.
And it's 2.5 lakhs is okay for a liver transplant. When you wanted to, when they're spending about 20-25 lakhs, we are okay to use that Hope for liver. But then for a kidney, it's not financially viable to use a Hope. So we use HMP, the LifePort 2. That's about 1 lakh. So
Okay.
that's somewhere acceptable with a kidney transplant cost of about 8 to 10 lakhs. Cadaver transplant, 1 lakh is okay to spend on a marginal organ to utilize the organ. It in fact increases the utilization of our marginal organ numbers.
What is technically easy, sir, from technical point of view? What is you find easy, Hope versus that is
Actually, Hope is an open system, so you can't do pre-ischemic perfusion. You can't take the machine to the retrieval center and take the organ and connect
transport
it.
is the
You
issue.
got to you've got to bring it to your own center, and then only you got to connect the Hope. Whereas LifePort is a portable machine, so you can take it with you. If you have a trained surgeon with you or a perfusionist who's trained enough to connect the organ, then you can take the machine to the retrieval center, retrieve it, put the kidney there itself on the machine, and while it's getting transported, it will still continue to get perfused. So that saves a lot of time. Technically, both are equally good, easy to do. Maybe LifePort requires a bit more, setting up is a bit more complex. Yeah.
Okay, sir. Sir, like a norm for normothermic regional perfusion, now we see in our country also in a DCD transplantation recently happened in Delhi. They use ECMO.
Yes.
So, do you find any role of ECMO or cardiopulmonary bypass machine, which is routinely available in our hospital? Any role of that
Yes,
perfusion?
essentially NMP is a modified ECMO.
Yes.
Normothermic, NRMP and NMP, they both are a modified. We started with NRMP. So we all started with the normothermic regional machine perfusion in DCD setting. That's how it all started. And then only the research into NMP started. And when we did the normothermic regional machine perfusion, we didn't use any special machine. It was just a simple ECMO. So we have a DCD, we connect them to ECMO, we assess the organs, then we take time to take it out instead of rushing in for a DCD. So, and NMP is also, like as I showed in my presentation, research that we did was essentially we modified, we did an indigenous NMP machine using a simple ECMO circuit only. And if you want to do, say, for example, you want to perfuse a kidney NMP, all you can do, retrieve the kidney, connect it to an ECMO machine, and perfuse the kidney, and you can use it whenever you want it to use. It's a simple ECMO. You just need to know the perfusion parameters, a well-validated perfusion parameters. That's all you need to identify and use it for the organ. So we know for liver and kidney exactly what are the parameters. It's all well-validated. Yes, certainly a ECMO can be used in your own hospital, a customized circuit with an ECMO. You can use it for any organ perfusion.
Okay. Sir, are you doing routinely it is in DCD transplantations or?
No, we don't do DCD transplants at all. Because I think that's something recently Avnish said and other people have started discussing about it. But then I was in the committee, but I couldn't really participate in any of the meetings. I don't know what's happening. We don't do it in our institution.
Okay. My next question is for ma'am. Ma'am,
Yes.
how, what is the maximum time we can put the organ on, say, in a live port or a hope?
I think the maximum time we've in fact put in an organ was close to about 7.5 hours. Now you have to understand that beyond the point, the ice is going to melt, and you may not be able to maintain the core temperature as well. So you'll have to in fact wait, replace the ice, and then restart the perfusion.
Okay. Ma'am, which patients generally do you target in case of kidney transplantation? For example, you may have in-house donor many, for example. So in that case also, you are each and every kidney you are putting on the machines or?
No, not every kidney. So if we have an in-house donor, we don't need to place it on a machine in all cases. Only in cases you're having, say, a marginal organ, or there's going to be some other form of delay. When, say, a logistic delay, if you're not having an in-house. Like we've had kidneys since we are from Tamil Nadu, so we have a lot of deceased donor programs which are running around all over the state. Be it even in the peripheral hospitals, be it within city hospitals as well. So in fact, we had a kidney which was coming in, if I'm not mistaken, either from Vellore or Virupuram. So these are places which are more than 100 kilometers away. So in those cases, in fact, we went there with the retrieval surgeon and just the nurse. The retrieval was done. The kidney was connected to the lifeboat machine and transported in the ambulance back.
Ma'am, who connect that? Because I see all of you are here only. And do you have any specialized team or that specialized people who go there and connect the kidney to the lifeboat machine?
The retrieval surgeon, as well as we have slowly been able to train a couple of nurses also to help out with the connection of machine as such.
So each and every kidney now coming to your hospital, for example, from outside center is through lifeboat only.
Not every center. So again, like we said, if there's a big logistic delay, right? So if it's say 50 kilometers away, as in I mean by say 50 or 100 kilometers away, certain organs which are marginal, yes, we would prefer putting them, especially if it's going to be of intermediate and high KDK, we tend to put it on the lifeboat machine.
Okay. Is Balaji sir is there?
I think
Balaji
Dr. Balaji
is
just
gone
received.
outside.
We just finished a transplant. So he's just
Please,
with the patient, so.
Okay. Ma'am, how you find in case of term of outcomes? So before this transfusion, or this perfusion machine and after perfusion machine, do you find what is it giving you more flexibility, more time, or what exactly?
So it has given us more flexibility in terms of extending the availability of organs which are available to our patients as well. So we're able to take in certain marginal organs, provide it to them. Of course, we discuss it with the patients beforehand itself, take a good consent from them as well in terms of using these sort of organs. Additionally, about the machine perfusion as well. So instead of only going in for standard criteria organs or donor organs, we're also able to use this and sort of put this into uses. And the other thing, when we're using these organs also, it is not about just taking it and putting it in, especially since we're going through the perfusion of the machine. We know whether these organs long-term wise also are going to be usable, or long-term wise they're going to have function, especially the delayed graft function rates are also going to be coming down since we're using them on the machine.
ma'am, since you people are doing such a wonderful work there, so just I want to, if someone in India wanted to start, in other part of India wanted to start this about our perfusions, how they should go? Should they utilize their in-house, for example, ECMO machine, or should they directly purchase live port machines? Or how they should start?
So I think this is a question I'm going to ask Dr. Swaminathan to
Yes,
answer.
yes.
If you want to start a machine perfusion program,
Yes, sir.
See, for I think this machine is easily available for kidneys.
Live
The
port.
HM, yeah, life port is easily available, and if you call them, they'll bring it there and they'll leave it to. See, if there is a good deceased donor program. To put it like this, like any if you are an active deceased donor kidney transplant program, or active deceased donor liver program, you'll have to probably perfuse all marginal organs, all marginals. I'm talking about in kidney, any ECD kidneys, any DCD kidneys, you'll have to perfuse it. It is clear, evidence is clear and evident that it is superior to static cold storage. So if you have an opportunity to perfuse, you can start with the HMP life port, which is very simple, cost effective, and it allows you to reduce the discard rates of marginal kidneys, which you would otherwise not use it at all. Say, for example, you have a 60-year-old diabetic hypertensive, and you have a high KDPI, calculated high KDPI, and you're waiting for your cross match, you're waiting for your flow cross match. There's a long cold ischemia as well. You're not going to use those kidneys because too many factors put together. In those times, you put it on the machine, you see the machine parameters. It's good, use it. If it's not good, you can discard it. So I think the best way to start is to get the HMP and start the kidney program, and hope and start the liver program. NMP, yes, it is near physiological, but then to set up a circuit, you need a really good perfusionist, somebody who's already worked in the field of NMP, and you need to know all the technical details of the tubing, perfusion parameters, the flow parameters, and how to assess the viability of the organs. We have for liver well-validated viability markers, including, the lactates, glucose extraction, potassium. All those parameters are there, bile production, bile composition, all those things. Similarly, we have a kidney. For NMP, we have some well-validated parameters. But then that's something not easy to set it up unless you have I think for now it's best to use some commercially available machines which are approved in clinical setting.
Thank you, sir. I would like to thank you all, Dr. Balaji, Dr. Anu ma'am, and Dr. Swaminathan sir. Thank you, sir. Dr.
Thank
Balaji
you.
is there.
Yeah, thank you. Thanks a
Thank
lot.
you
Yes, sir.
for having.
Thank you all your teams. It was wonderful to. It was good to learn you. It's new things for all of us. The machine perfusion is the future. It will surely increase the outcome and again the acceptability. So now think we have to move forward just for transplantation and to increase the quality of organ transplantations. So moving in that directions, the perfusion will have its own role. So I would, on the behalf of Indian Society of Organ Transplantations, I would like to thank you all and looking forward to learn more from you, from your groups. My best wishes to you. Thank you, sir. Thank you, and good night.
Thank
Thank you
you.
for having us.
Thank you for having us.
Thank you.
Thank you.